Okay, good morning everyone. Following that invigorating stretch break, we'll move straight on to our first plenary. My name's David McCarty. I'm a cardiologist and associate professor at the Schulich School of Medicine and Dentistry in London. And on behalf of the Professional Education Advisory Committee, I'd like to welcome you in the room and on the webinar. And the committee has lined up an engaging list of speakers across range of our special population subjects. So we've got speakers who are going to address the issue of frailty in the elderly, pregnancy and heart disease, and then athletics and heart disease. And I'm delighted to welcome our first speaker, Dr. Alan Huang. Dr. Huang is the head of the Division of Geriatric Medicine at the University of Ottawa and the Ottawa Hospital. He's a graduate of McGill University and has previously held the posts of Director of the Division of Geriatric Medicine at McGill and also the Programme Director for McGill Postgraduate Residency Training Programme in Geriatric Medicine. Dr. Huang's a long-standing interest in clinical informatics. We've been hearing about that already today. And he's the co-inventor of the Medical Office of the 21st Century, or MOXIE, electronic prescribing solution, which has provided a system on which 20 years of research into optimal prescribing and expert decision support has been developed. So I'm delighted to welcome on your behalf Dr. Huang, and he's going to be addressing the subject, heart interventions in older people filtering for frailty. So Dr. Huang.
Okay, thank you and good morning. It gives me great pleasure to be up here to present to you on something that's near and dear, but also a bit mysterious to geriatric medicine, this thing called frailty. So I have no conflicts of interest to declare. Potential bias has been, you see my statements there. And at the end of this session, you should get a sense of what is this thing called frailty? You sort of all recognize it, but what is it really about? I want you to be aware of cognitive screening tools at the end of this presentation, and also to generate a framework for patient-centered decision-making, because we've got all sorts of new technologies coming up. We can do anything to almost anybody, and the question is, should we at some time? Okay, set the context, demographics. The world population is over 7 billion now, and the proportion of people over the age of 65, how we define elderly, which may be changing, is different in different countries. And our Canadian numbers are there, 36.6 million people in Canada, of which 13.6 are in Ontario, and if you calculate it down, it's a little more than 2.1 million people in the province of Ontario that are older than 65. And the baby boomers, again, the estimates and the calculations may be different, but the scary figure is that 1,000 Canadians every day turn 65 or older. So today, tomorrow, the following day, another 1,000. So in fact, for the Champlain-Lynn, where I'm based near Ottawa, there's at least 3 new 65-year-olds every day. So for me, it's job security, right? So, and it's going to happen for the next 17 years. So any of the trainees out there, okay, geriatric medicine, this is where we're going. Population pyramid is changing. So what do I mean by the population pyramid? We've seen these demographic images before. So this is for countries such as Cambodia with 16 million. Yeah. Looks like that, right? Okay, pyramid. Here's what Canada looks like today. Our population distribution. We may not want to fit that particular pattern, right? It may not be that bad. October 1st every year is International Day of Older Persons as declared by the United Nations. And last October 1st, this is what they want to focus on, stepping into the future, tapping the talents, contributions, and participation of older persons in society. So this is a very important demographic slice of humanity. So this question, what is frailty? So here are 1, 2, 3, 4, 5, 6, 7, 8 images of older people. And, this is almost like a joke. An internist, a geriatrician, and a cardiologist walk into a bar and they see these people in the bar. First of all, why are these 8 people in the bar? So then the main question is, how many of these older people do you consider as frail just by looking at them? And of course, we have our own images of what is frailty, right? So I didn't create a clicker question here, but how many would say 8 of these were frail? You just sort of raise your hands. Okay. 7 of them. 6, 5, 4, 3, 2, 1, and none. Okay, so you had a distribution around 4-ish, right? You may be surprised when you start applying some frailty assessment tools to these individuals, whether you would discover they are truly frail. Okay, so how can we assess frailty? There's 3 ways that have been published, and the first is what we call rules-based, and the second is an index variable, and the third is clinical judgment, which is the simplest for us clinicians because we don't have to look anything up. We just use our clinical judgment, the eyes and ears and the nose. So rules-based, Linda Fried in the US had created this frailty phenotype several years ago. And then the index variable came about after the Canadian study of health and aging, the first one, which I think was completed in 98 or 99. And they used 70 items. Of course, you're never going to remember 70 items. So again, after that was created, there was this clinical judgment scale. I keep misnaming it the Canadian Frailty Scale because it was developed by Ken Rockwood and Dalhousie, but it's actually, its official name is the Clinical Frailty Scale. So I can sometimes interchange Canadian versus clinical frailty. Okay, so what does the frailty phenotype look like? And the Americans like to measure things, right? So this is why the Linda Fried frailty phenotype thing has things you can measure. Weight loss, okay, pounds, kilos. Exhaustion, you can ask somebody a question. Slowness, in terms of gait speed, whether they walked a particular speed of meters per second, etc. Low activity level, and weakness, so you can get them to squeeze a dynamometer. So if you classify them, they have none of these things, they're not frail, and then if they're frail, they have 3 or more of these things. This is what the CHSA Frailty Index looks at, 70 items. Like, no one's going to remember that. But in fact, for larger population-based studies, you can actually look at these items that are captured in even administrative databases, such as the ISIS data stuff in Ontario, and you can actually pick out who would meet these frailty index positive or negative states. So this is not really good for clinical use. Here's the clinical frailty scale. You've got a little cartoon and a descriptive paragraph from very fit to terminally ill, and any of you who have been in clinical practice for more than 6 months can usually suss out what that individual looks like and put them on a scale of, are they 3 or 4? Are they managing well to vulnerable, or mildly frail or moderately frail? And between observers, there's a pretty good agreement. So this works. It's easy to use and it works. So all of us, we've got all sorts of systems going, integrated, hopefully well, and our body is a temple, and this is successful aging. This is what frailty does to it along several aspects or axes. So mobility, functional dependence, cognitive problems such as dementia, and social isolation. So this is where our temple starts to have cracks and fails. And the other image of frailty or fragility is if you look at a fine china teacup, you look at it and say, oh, that teacup is fragile. You might not necessarily say frail, but you would say that little old lady is like a little teacup and say, okay, that's what frailty means to me. But if you took that new teacup, turned it upside down, put it on a flat surface, put a piece of plywood on it, you could stand on it. Nothing would happen to that teacup. It's only when you chip the rim by putting it into the dishwasher with other things and you have a little chip, you couldn't do that anymore. That teacup would shatter, so it was fragile. But sometimes we have that image of fragility or vulnerability leading to frailty. The more frail you are, the worse off you are in terms of morbidity, mortality. And these downward curves basically say that from various studies. If you look at the Fried phenotype or the clinical frailty scale definition of frailty, the more frail you are, the worse off. So, frailty. Try and identify it. What do we do with this data? Now, I'm going to give you an example back to the basic sciences. Years ago, they developed this technology called FACS, fluorescent activated cell sorter. It's actually in use today. That's how we get our cell counts out of various lab tests. So this fluorescent or this laser beam activates these cells, and they fall into different buckets. What I'm going to propose to use FACS, F-A-C-S, and change the words to frailty activated case sorting, so that the population in front of you, all 65, 75, 85-year-olds are not the same. This goes back to the genetics and the environment, so that as people get older, they become more and more heterogeneous. So you need to have these frailty filtering tools to figure out who's frail and who's not. So if you have something that can allow you to detect frailty, then you may make different decisions. And it's certainly involving the patient and their family and say, well, they may not understand what frailty is as a term, but they understand that they are failing and things aren't as good as they used to be. So they'll have an understanding without the word. So one of these tools is actually called FACT, the Frailty Assessment for Care Planning tool. Again, Dalhousie and Halifax have been good at developing these tools. This is actually the simplified care planning tool, the FACT tool, and then you see along the top row those 4 pillars, so mobility, social function, and cognition. And along the column on the left-hand side, you see the good to the bad. So you're okay at the top, and then at the bottom, you're terminal. So this is actually downloadable if you search for the FACT tool. There's a PDF file. So just drilling into some of these details. So if you look at mobility, stage 1 and 2, you're thriving and very well, and stage 8, you're bedbound. So you get a sense, this is very clinical, right? So you can put people on this FACT tool. You can circle where they are. In fact, the FACT tool can be done by an observer, a family observer. In fact, while they're waiting in the waiting room, you can have them do the FACT tool while they're waiting to see you, and then you can already determine whether they are coming in with frailty. Looking at function, still working at job or a high-level hobby, to dependent on all aspects of daily life. Social, in charge of organizing social events versus unable to participate in any social exchange even when visited, so they don't even recognize the visitor. And finally, cognition, thriving, impresses others with memory and thinking versus limited language skills with less than 10 words verbalized. Very clinical, very observable by a close observer, so a family member or a neighbor or whatever. So I want to focus on the detection of cognitive problems. It's really important that all of you have something in your toolkit, in your clinical toolkit, that allows you to get a sense of how someone's functioning cognitively. At the age of 90, 25% are going to have major cognitive problems. Not bad. That means 75% don't, but they're out there free-ranging. We don't see them, right? So it's ones that come to our attention that we need to be careful. It's there, it's under-recognized, and if you have significant cognitive impairment, it's going to predict a whole lot of negative outcomes, especially delirium, with hospitalization, with procedures, with anything. And delirium can really rip things apart. It increases length of stay, they fall, they need sitters, increased costs, bad things. Death follows quite soon after those delirious episodes, long-term placement. So all these negative outcomes are associated with the root cause of underlying cognitive impairment. So if you can detect it anywhere in your pathway, it's good because it can change the decision making and perhaps the pathway of what happens to that individual in the immediate and medium term. So screening tools, there's lots of cognitive screening tools out there. Pick one, use it consistently. You can actually delegate somebody to do the MOCA or the other tools. I list several there, and all of you with your invite email, there's a link to all the presentations, and I have a supplementary file that's included there. And if you, of course, deleted that email, you can always go back to the website for this conference and the links to the presentation, so it should be there. Because I've included all these tools in that PDF file. One thing about the MMSE, the Folstein Mini Mental Status Exam, is the new publisher who owns the rights, the copyrights, has put out into the world consciousness that they want to charge you $1 use for the Mini Mental Status Exam every time you use it outside of a registered research trial. And everyone will say, they're not going to get me. I'm in my private office. How are they going to know? They know. So that's why many of us have moved on to the MOCA, the Montreal Cognitive Assessment Tools, and other ones because they're freely available, open source, etc. The RUDAS is actually interesting because it is language independent. It was actually developed in Australia for Chinese-speaking, unilingual Chinese-speaking individuals or Aboriginals in Australia who spoke neither language, etc. So it's interesting. Okay, so try to put it all together now. Unless you're doing pure pediatrics, you're going to see old people in your practice, guaranteed. I'll be there. You need to filter for frailty because it will impact on your decision making, your discussions with the patient, their family, and what you want to do for them and what you're going to offer to them, especially those for 80-year-olds, 80 and over. I mean, geriatrics and elderly was supposed to be 65 and older, right? The closer I get to 65, the more I want to push that forward. I'm not geriatrics yet, even though Canada has sent me this invitation saying, you can sign up for your Canada pension plan any day now. I'm not ready for that. So 80-year-olds and older, they're really, really heterogeneous. So I would say screen all those well. Do some sort of cognitive screening, and once you get used to it, you can be surprised at how fast you can do it and how well it detects things. Once you've got that state of frailty, so these tools don't tell you a measure of frailty, it just tells you whether an individual is frail or not. It's not like a blood pressure measure that you've got a number that's lower versus higher. It can tell you whether someone's frail and perhaps a bit of a degree of frailty, but you're either into that bucket or not. So again, informed consent, if someone's cognitively impaired, that changes it. You may need to involve their substitute decision maker. And again, if you're going to think about an advanced cardiac procedure such as TAVI or exercise stress testing to look at coronary arteriography, et cetera, down that particular cascade, and the person's severely demented and bedbound, you may want to double think that and say, am I going to reap, or is the patient going to reap the benefits of everything that I'm going to do? So again, putting it all together, if you need help, as geriatric medicine specialists, we're very few across Canada. But when you think and see one of us and you say, well, how can we help? We have an easy way to remember, and this is what we've labeled as the geriatric 5 M's. We are experts in, but not limited to, things that have to do with mind, mobility, medications, multi-complexity, that's 4 or more concurrent conditions, and what matters most to the patient. So we actually put this hand image up, so there's 5 fingers and 5 M's, and people remember that quite easily. We aim to create patient-centered decision-making, and again, for those of you in primary care role out there, and you're starting to think of advanced interventions for your older individuals, and if you discover frailty in that individual, it's much better to start talking to them about what they really want out of life, what's important to them, what matters most. Because again, if you start thinking about these advanced interventions that you just heard about from this conference or the last one last month, does it really make sense to them? The information's out there, so they and their families will find out anyways. So it's better that you start that conversation before they start thinking of, oh, I want this and I want that and I want the other thing that may not be appropriate for them. Again, quality of life is important, person-reported outcomes, and one of our sort of taglines is adding life to years, because we can't really fix very much that's happening with our older individuals. And again, this is a bit of a word cloud in terms of putting all the concepts together. Again, screen for frailty. You'll find it out there. Once you find it, you'll be glad you found it, because it changes the conversation and everybody will be happier for it. Thank you.
Okay, well, I'd like to thank our first speaker on your behalf, and I should say that all of our speakers will be returning up at the end of the 3 presentations for a question and answer session. Now, if you're in the room today, you can ask a question in 2 ways. There are pens and papers on all the tables, so if you like, you can jot down your question now, and we'll shortly, when the question time comes up, we'll have people go around and collect your question. So if you've got a question and you don't want to forget it, you can quickly write it down on a piece of paper and we'll pick it up later. The other way we'll be handling the question and answer session is that we've got a couple of microphones in the room, so you'll have the opportunity to come and ask your question in person. Now, if you're attending on the webinar, you're free to ask questions at any time, and there are a few of the technical support staff here who will jot your question down and pass that on to us at the question and answer session.